Welcome to IPOPI Hard Talks. My name is Martine Pergent. I am the president of IPOPI, and it is my pleasure to co-moderate this digital event with Dr. Nizar Mahlaoui. Hello, Nizar.
Hello, Martine. Hello, everyone. I'm Dr. Mahlaoui. I'm a pediatrician and I work at the Necker Hospital here in Paris. I'm a chair of the IPOPI Medical Advisory Panel, and I'm very glad to co-moderate this event together with you, Martine.
First, let me take a moment to thank our sponsor, Savara, for making this event possible. Before we start, let me remind you the IPOPI Hard Talk concept. With IPOPI Hard Talks, we explore the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. The theme today is Diagnosis of Autoimmune Pulmonary Alveolar Proteinosis, autoimmune PAP. To engage in this discussion, I'm delighted to welcome our challenger today, Dr. Leif Hanitsch from Germany. Dr. Hanitsch studied medicine in Berlin and immunology in Oxford. He is leading senior consultant at the Institute for Medical Immunology, Charité, Berlin, and takes care of adult patients with primary and secondary immune deficiency, as well as autoinflammatory disorders. Dr. Hanitsch coordinated and contributed to several national and international clinical guidelines. His scientific focus is infection immunity and immune dysregulation in adults with PID patients. Leif Hanitsch is a member of the Scientific Steering Committee of the German Patients Organization for PID and FOCSIT Director Board member. Welcome and thank you.
Thank you.
Welcome, Leif. And I'm pleased to introduce the presenter today, who's Dr. Maria Kokosi from the UK. Maria is a consultant in respiratory medicine at the Royal Brompton and Guy's Hospitals, UK, and an honorary clinical lecturer at Imperial College. Dr. Kokosi completed her training in respiratory medicine in Greece in 2011. Maria joined the Royal Brompton Hospital as a clinical research fellow in 2012 and received a consultant post in 2018. Her specialist interest is in interstitial lung diseases and in particular rare lung disorders such as cystic diseases and pulmonary alveolar proteinosis. Maria leads the service for the rare cystic lung diseases as part of the Cystic Lung Disease Rare Disease Collaborative Network, and Maria is actively involved in research and is the principal investigator in clinical trials in rare disorders. And she's also a co-investigator at the Life Arc Center for Rare Respiratory Diseases. Maria, we are very honored to have you with us today. Warm welcome.
Thank you. Thank you very much.
So welcome to both of you. And how will this hard talk work? Dr. Kokosi will soon give her lecture, and after the lecture, Dr. Hanitsch will share his comments, and together we'll discuss and debate this topic. During the presentation and the discussion between the two guests, you will be able to send written questions in the question tab. So let's begin. Dr. Kokosi, the floor is yours.
Thank you. Thank you. So my talk will focus on the diagnostic approach of autoimmune pulmonary alveolar proteinosis. These are my conflicts of interest, and I will start. My first slide is on the pathogenesis of autoimmune alveolar proteinosis. Normally, the alveoli, the function of the alveoli is maintained by a surface, the surfactant layer, which is thin enough to allow the diffusion of oxygen through the alveolar walls, but at the same time is thick enough to reduce the surface tension. And this is very, very important. The balance is maintained, the balance, what we call homeostasis, is maintained by, on the one side, the secretion, the production of surfactant by alveolar epithelial cells type 2, and clearance of surfactant by alveolar type 2 epithelial cells and alveolar macrophages. And for this homeostasis, what is very important is GM-CSF. You see it here. What happens now in autoimmune alveolar proteinosis is that anti-GM-CSF antibodies bind and block GM-CSF on the receptors on the surface of alveolar epithelial cells. This results in accumulation of cholesterol, lipids within the alveolar macrophages, accumulation of surfactant lipids, because surfactant is mostly consists of lipids, including cholesterol, and they give this very characteristic appearance of foamy macrophages. And the function of macrophages is affected, as well as the clearance of surfactant, which accumulates within the alveoli. With time, we see in the alveoli the surfactant sediment, cholesterol crystals, and cellular debris. And this results in impaired oxygenation, respiratory failure, and shortness of breath on exertion. Autoimmune pulmonary alveolar proteinosis is the most frequent form of PAP. It actually accounts for 90% of the cases of with PAP. And before I discuss the diagnostic algorithms in autoimmune alveolar proteinosis, I will share a case from my clinic. 23-year-old who presented with a 12-month history of insidious onset of shortness of breath and cough. He is a medical student and reported using cannabis just occasionally, but not regular smoking. For many months, he was treated for presumed asthma with inhalers with minimal clinical improvement. And during a respiratory physiology lab session he had in the context of his studies, he volunteered for a spirometry, which surprisingly was restrictive. And alarmed by this, he tested his oxygen saturation on exertion, which dropped to the low 80s. Of course, this prompted a referral to the local respiratory team, and he underwent a CT, which you can see here. And there is diffuse ground glass changes with interlobular septal thickening. It's a typical crazy paving pattern. So we have here typical presentation, and as you see here from 3 patient cohorts with PAP, Japan, Germany, and Italy, the majority of the patients present with shortness of breath and cough. In the German cohort, almost half of the patients also reported fatigue and weight loss. So clinical presentation typical and radiology typical with crazy paving, but no way pathognomonic. Crazy paving is not pathognomonic for PAP. We can see crazy paving in other disorders such as pulmonary edema, alveolar hemorrhage, hypersensitivity pneumonitis, acute lung injury, pneumocystis jirovecii pneumonia, etc. With this information, what should the next step be? We should test for anti-GM-CSF antibodies, which can confirm the diagnosis of autoimmune PAP, and consider bronchoalveolar lavage, which can further confirm the diagnosis of PAP, but also can rule out infection. What happened in reality was a lot different. So this patient was referred by the local respiratory team for a VATS biopsy, and the slides are provided by our pathologist, Professor Andrew Nicholson, and it showed a picture typical for alveolar proteinosis with alveolar spaces filled with granular eosinophilic material consistent with accumulation of surfactant. Pus stain was positive, there were foamy macrophages, and importantly, alveolar architecture was well preserved. So in this case, we have two issues. First of all, the diagnosis was delayed because the patient was misdiagnosed with asthma and treated as asthma for a while. And the second is that the patient underwent an invasive procedure, which was probably unnecessary. So cases like that highlighted the need for clear guidelines for the diagnosis and management of pulmonary alveolar proteinosis. So an ERS task force was established, and you see here the team posing in the Luxembourg Gardens in Paris. The guidelines were published in 2024, and they provide updated guidance on the diagnosis and management of PAP. This diagnostic algorithm is included in the guideline, and what it suggests is that patient with compatible history, as the case I presented, and typical radiology, with or without additional information from bronchoalveolar lavage, should immediately undergo GM-CSF antibody testing, serum anti-GM-CSF. This is the first test to consider. If the test is positive, autoimmune alveolar proteinosis is confirmed. If anti-GM-CSF antibody testing is negative, we need to look for any conditions, any diseases that can cause PAP, such as hematologic malignancies or other malignancies, for example, or AIDS, other immunodeficiencies, occupational exposures. If any of those is present, this is secondary PAP. If none of those is present and anti-GM-CSF antibodies are negative, we can organize further investigations, and I will come back to that later with my talk. But what I want to highlight is that biopsy should only be considered when all non-invasive tests have been done and they have not given us a definite diagnosis. And I will go through the different diagnostic tests, starting from the bronchoalveolar lavage and the biopsy, and I will finish with the anti-GM-CSF antibodies because I want to give weight on that test. It's very important. So bronchoalveolar lavage, very characteristic appearance. It is cloudy, milky, turbid, as you see here, these pictures, positive, pus positive, and contains foamy macrophages. You see here my colleagues, Dr. Cliff Morgan and Tom Pickworth. They are the ones who do the whole lung lavages and in our center. What is the diagnostic yield of bronchoalveolar lavage and how often is it used? So we have here three patient populations. From the US, 410 patients, only 4 of them underwent bronchoalveolar lavage. 71% of them had a surgical biopsy, 10% transbronchial biopsy. Japanese cohort of 250 patients, 70% underwent bronchoalveolar lavage, 44% surgical biopsy, 12% transbronchial biopsy. Chinese cohort, 240 patients, 72% underwent bronchoalveolar lavage. We do not have data on the biopsy. And the German cohort, 70 patients reported by Francesco Bonella, 76 patients underwent bronchoalveolar lavage, 34% surgical biopsy, 29% transbronchial biopsy. So you see huge differences between different continents, which is not only relevant to PAP, it probably reflects the practice in interstitial lung diseases in general. What is the diagnostic yield of bronchoalveolar lavage? This is a Japanese series of 150 patients. Bronchoalveolar lavage was diagnostic in 91% of the patients, and when combined with transbronchial biopsy, the diagnostic yield reached 99%. So the role of bronchoalveolar lavage, according to the guidelines, it is recommended to be performed as part of the diagnostic workup of patients with suspected PAP and should include differential cell count, pus staining, in order to confirm the diagnosis, but also microbiology. And what are the advantages of the bronchoalveolar lavage? It can confirm the diagnosis. It can rule out infection. It is a procedure, low-risk procedure. It can be performed in most institutions, and when discussed with the patient representatives on the guideline committee, it is preferred compared to biopsy. Let's look at the biopsy now. And this is data from the US National PAP Registry. So 30% of the patients underwent surgical biopsy, 29% transbronchial biopsy, combination of the two, 23%. And only 18% of the patients did not have any kind of biopsy, which is again impressive. And even more, in 1/3 of the patients, the histology did not give a diagnosis, was not conclusive. And this is partially because of the nature of PAP, because it has a patchy distribution, so probably a blind transbronchial biopsy could miss the diagnosis. Site selection is very important, but surgical lung biopsy, where the site of biopsies can be carefully chosen, then should give a diagnosis in all the cases. So for me, this raises questions about the quality of the procedure as well. And this is data from the whole US, from different centers with expertise or not. And this is data from the Japanese registry, 250 patients with alveolar proteinosis. VATS biopsy, only 7% of the patients. Huge difference between the two continents. And of course, it is an invasive procedure, and it is associated with complications, either immediate or long-term. So this is the downside of the biopsy. And having discussed the transbronchial cryobiopsy, which is a blind procedure, surgical biopsy, we might have a compromise actually, and this is a cryobiopsy, and which gains more and more space in the diagnosis of interstitial lung diseases and probably pulmonary alveolar proteinosis. For the moment, we only have some case reports, and some of those I have included in this slide. But the positive here is that compared to the traditional transbronchial biopsy, the samples are larger and more intact, and at the same time, with navigational techniques, somebody can target specific sites. And these are pictures from cryobiopsy in a patient with PAP, kindly provided by Professor Venerino Poletti from Forlì, Italy. You will know him as a guru of cryobiopsy. So it is a procedure to consider when a biopsy is needed. Again, it should not be done routinely. Biopsy in general should not be done routinely in PAP patients before referring to an expert center. But if a biopsy is considered, cryobiopsy could be a good compromise. There are cases, though, where the biopsy is important, and I have included two cases here. 42-year-old male heavy smoker with 12-month history of worsening shortness of breath and exertion, presented with this CT to the local hospital. So diffuse ground glass on a background of what looks like cystic changes. The patient was initially managed as acute lung injury, treated initially with antibiotics, although there were no infective signs, then with high-dose intravenous corticosteroids with no response. He was on high-flow nasal oxygen, 60%. We were contacted for advice as an expert ILD center. We discussed the patient in our multidisciplinary meeting. Our radiologists were concerned about malignancy. So the patient was transferred to us for a CT-guided biopsy, which is quite risky given the clinical status of the patient and could not be done locally. And the CT-guided biopsy showed pulmonary alveolar proteinosis with positive anti-GM-CSF antibodies, so nothing like the crazy paving pattern that I showed. The patient had whole lung lavage and was commenced on inhaled GM-CSF, inhaled molgramostim. This is the CT 6 months later. So here the diagnosis and the biopsy was very important. And the second case, 59-year-old female, heavy smoker with a 6-month history of worsening shortness of breath on exertion and bronchoria. Presented with this CT, again, the local hospital admitted, high oxygen requirements, was referred to us for possible alveolar proteinosis. And there is diffuse ground glass, there is maybe some septal thickening, but not the typical crazy paving. Again, discussed in our MDT with our radiologists, they again favored malignancy. The patient was transferred for a CT-guided biopsy and it showed mucinous adenocarcinoma. So these are the cases where we need to consider biopsy. And I will move on to anti-GM-CSF antibodies, which have an important place in the diagnosis of autoimmune PAP. Anti-GM-CSF antibodies are significantly increased in patients with autoimmune alveolar proteinosis compared to the other forms of PAP, other lung diseases, and healthy individuals. They have been in use for 2 decades now, and the sensitivity and specificity of the test is reported 100%. So very diagnostic of autoimmune PAP. The GM-CSF antibody levels do not correlate with disease severity, with lung function tests, or prognosis. But it is not only the presence or absence of antibodies that is important. The actual antibody titer is critical. And why is that? We have here the reference range for the antibodies: abnormal above 10.2 micrograms per milliliter, normal below 3.1, and we have an indeterminate range. And you see here that a small proportion of patients with autoimmune PAP and healthy individuals fall within the indeterminate range. What should we do then? So we can do additional testing. We can test the GM-CSF signaling, which is not a test that is done routinely. It is provided by Bruce Trapnell's research group in Cincinnati. And it actually, what they use is the STAT5 phosphorylation index test. And what is the logic behind it? STAT5 plays an important role in the development and function of alveolar macrophages. If STAT5 phosphorylation is disrupted for any reason, it leads to dysfunction of alveolar macrophages, this disruption in the GM-CSF signaling pathway, and accumulation of surfactant. In autoimmune PAP, as we saw, the GM-CSF antibodies are blocked. They cannot bind to the receptors on the surface of alveolar macrophages. As a result, the GM-CSF signaling pathway, including the STAT5 phosphorylation, is disrupted. And what the test does, what we actually do, in blood collected from our patient, we add exogenous GM-CSF and we see whether the STAT5 phosphorylation takes place or not. And in autoimmune PAP, we expect the STAT5 to be very low. The phosphorylation, the activation of the STAT5 will not go ahead. The same is the case in other forms of PAP, for example, hereditary PAP, where we have mutations of the receptors, GM-CSF receptors. They are dysfunctional. Again, there we expect the STAT5 to be quite low. But in secondary PAP, in a PAP due to hematologic malignancies, etc., the STAT5 phosphorylation should be normal. Serum GM-CSF can also be helpful and can be elevated in hereditary alveolar proteinosis, while it is absent or very low in autoimmune alveolar proteinosis. So there are additional tests to be done to guide the diagnosis, either in patients with autoimmune disease, but in the indeterminate range, or in other forms of PAP, but not yet in the clinical practice. And to say that, before I finish, to highlight that alveolar proteinosis is a very rare condition. It is often underdiagnosed and not appropriately treated. So it is very important, if you have a patient with suspected or confirmed alveolar proteinosis, that they are referred to expert centers, because they can have access to diagnostic tools, they can have access to different treatment options, but also to any research developments. So referral to an expert center and a multidisciplinary meeting actually gives your patient the best chance at an accurate diagnosis and appropriate management. And my topic is not today the treatment for autoimmune alveolar proteinosis, but I'm adding this algorithm here from the guideline. Whole lung lavage and inhaled GM-CSF are the first line treatment for autoimmune PAP, depending on what is available in each center or in each country, depending on the disease severity, with rituximab and plasmapheresis having a role of second-line therapy. And to conclude, clinical presentation and radiology determines the diagnostic likelihoods of pulmonary alveolar proteinosis. When you suspect alveolar proteinosis, always and first of all test for anti-GM-CSF antibodies. Consider bronchoalveolar lavage for diagnosis, but also for microbiology, and do not perform surgical biopsy before referring the patient to expert centers. Thank you.
I was saying now we can enter into the discussion. How do you see this, Dr. Leif?
Okay, yeah, great presentation. Thank you very much, Maria. I would like to start maybe with a clinical question. The case that you presented, the history told us that the patient presented with asthma, and then the pulmonary function test showed us a restrictive pattern. And in the conclusion slide that you had, you mentioned that you have clinical and imaging hints. What is the position of pulmonary function test? Is there anything really conclusive we can get from that test, or is it always a bit difficult to interpret?
Yeah, so the lung function, I cannot say it is characteristic for alveolar proteinosis. It is characteristic for alveolar filling processes. So what we see is a reduced gas transfer as expected. In more advanced disease, the forced vital capacity is reduced, but it is a pattern that we see, for example, in interstitial lung diseases in general. So it's not going to raise suspicion for PAP. The patient I presented was diagnosed with asthma without any symptoms suggestive of asthma or without really a spirometry. The diagnosis was based just on symptoms of shortness of breath and his young age, 23 years old. So his general practitioner felt that it was the most likely diagnosis. And it's, I have to say, we see that quite often.
And following along that line, so this patient was young, you said. Is there a typical onset of disease? Is it something that is more affecting the younger patients or appears later in life?
So the age is usually between 30 and 60 years old. I would have to say the patients are usually probably in their 40s, but we do see younger patients like the one I presented. It's rarer in older patients, I have to say, but again, it's not excluded.
So the community of physicians that do take care of patients with inborn errors of immunity, we come across the mentioned anti-GM-CSF antibodies in a complete different context. So in our clinic, they would usually be a sign or something to suspect in patients that suffer from very specific central nervous system infections, and that is nocardial infection and Cryptococcus guttei infection. Is that something that you sort of have to look for in your patients as well, because they have those antibodies?
Yeah, so autoimmune alveolar proteinosis is associated with opportunistic infections or unusual infections, like you mentioned. And it is interesting that those infections are not isolated in the lungs necessarily. We can have disseminated infections, so nocardia with brain abscesses, or we can have aspergillus, non-tuberculous and tuberculous mycobacteria. We do need to look for them, and we need to have in mind that our patient might not necessarily have respiratory symptoms only, but also CNS involvement, etc.
Okay, now I'm being the devil's advocate.
Okay.
So if we say that we also expect that these sort of infections are going to take place in the patient, then wouldn't it be better to treat them directly to sort of address the source of the autoantibodies? So in your chart, you have rituximab as a later place, but at the first place treatment, you sort of treat the symptoms by addressing just the injection between GM-CSF and the macrophages. So is it something that happens very often, or is it a rarer case, so that's why it's okay to go down the line and first do the GM-CSF treatment?
Yeah, it is not as frequent. So in my experience, for example, and we have a large cohort of almost 100 patients over the years, we had only 1 or 2 nocardia infections. I haven't seen that very much. So it is there, and it is reported, but it is not very frequent. Also, the link of antigen, there is definitely a link between anti-GM-CSF antibodies and PAP, but the exact association with infections is not very well described in PAP.
Yeah, so the field of immunodeficiency, I think it's still not fully understood. So Cryptococcus guttei is usually something that is not seen in sort of compromised patients. It affects mostly the immune healthy individuals, and I think it's endemic in the Vancouver region, but it's generally something that is probably underdiagnosed. Do you see a certain pattern of distribution around the globe that you say, oh, this ethnicity is more susceptible or more prone to develop alveolar proteinosis?
No, there is no data really to suggest that there is an ethnic predilection. There are some studies, older studies, which have identified some HLA alleles, for example, in a Japanese or a Chinese population, not in European. They haven't found any HLA alleles. So there might be some susceptibility, but it does not translate to increased incidence of the disease in certain ethnicities. Okay,
yeah, interesting, because with regard to other autoantibodies against cytokines, we spoke about that before. In our field, we have patients that do suffer from autoantibodies directed against interferon gamma. And there is very important work by a group from Taiwan that also showed this HLA association. and they did a nice experiment showing that there is a certain strip of interferon gamma which has a very high homology to Aspergillus. So the current understanding is that there is a type of molecular mimicry, that those patients have had an infection against Aspergillus first time, and the generated antibodies are now not only recognizing Aspergillus, but also this part of the interferon gamma. Is there something known about the anti-GM-CSF antibodies in terms of molecular mimicry, if there has been a previous infection that could have generated these antibodies?
No, there isn't any data that at least to my knowledge, that to any previous infections could have triggered the development of anti-GM-CSF antibodies. In general, the understanding of the disease is not yet full, and there is a lot more to understand with regards to the pathogenesis, especially the role of the antibodies. There is a lot of focus on treatment because, of course, it's a concerning disease, but we still yet have to understand it.
And if I may ask another question about these anti-GM-CSF antibodies in terms of testing. So it's ranked very high in the algorithm. So you should go first and test for these autoantibodies. Yet at the same time, it's not available everywhere. So do you have to send it most of the times somewhere else? How long is the turnover time? Can you wait such long time, or is it putting the patient at risk?
So it is a challenge. It's a very nice question and observation. Even in the UK, anti-GM-CSF antibody testing takes place in one center in Cambridge. So we have to send the antibodies. Usually turnaround time is 2 weeks. We can have the results faster if we need them urgently. But there are countries where the antibody testing is not available at all, and they have to send it abroad, and not always funding approved by the health system. So this is a major limitation. It is important though, because we have treatments for autoimmune alveolar proteinosis, inhaled GM-CSF. So it is important to know, even if we have managed to confirm that it is PAP with the bronchoalveolar lavage, the radiology, etc., we are certain that it is PAP. It is important to confirm that whether it is the autoimmune form or not, because we have newer treatments now, and it is important to be able to provide that to the patient.
Mm-hmm.
If now we have a patient with PAP, not known antibody status, severe disease, we can anyway go ahead with whole lung lavage. The restriction is when it comes to inhaled treatment. Okay.
So imagine you would practice in a country where you don't have access to the autoantibodies. What would you recommend to those physicians? Would you go ahead for lavage and establish the clinical diagnosis and then assume that it could be autoimmune PAP? Or so how would you approach then if you don't have access?
So definitely whole lung lavage in order for the patient to improve. And again, it depends whether it is available in a certain institution. It's not done widely. But if it is, then definitely whole lung lavage to give us some clinical improvement. At the same time, try to find to see if it is possible to test and send the anti-GM-CSF antibodies even abroad, because it will add the patient, it will change the patient's management if it is autoimmune. They cannot start inhaled treatment if autoimmune disease is not confirmed.
Mm. And so when you do the lavage, usually we have like an abundance of alveolar macrophages in the lavage. Are those diminished in those patients as well, or they are there but they just don't do the job?
Yes, they are there. They look unusual, but they are dysfunctional.
Okay, so they're there and you have a different cytology as a picture, but if you would do like a differential count, you see they're still there.
Yes, yeah.
Okay, I see. And another question that I would like to ask you, in your experience, is perhaps something that happens with a very sort of sudden onset, or is it something that builds up gradually?
It is a gradual onset of symptoms. The patients can have symptoms for a year or even 2 years before they are finally diagnosed. So acute deterioration will happen if the disease is complicated by an infection. This is where we see acute exacerbations, acute worsenings.
And again, coming from the world of inborn errors of immunity, we have a very important relationship with genetics. What kind of patients with suffering from alveolar proteinosis would you consider to be a good candidate to do genetic testing?
So in an ideal world, the patients who have negative anti-CSF antibodies should be tested for the genetic forms, hereditary or congenital alveolar proteinosis. So that would be the pathway, but definitely we should consider it if the antibodies are negative. Of course, the other thing to consider there is, could it be secondary PAP, secondary to, as I mentioned, hematologic disorders, leukemia, lymphoma, myelodysplastic syndromes, etc. If that is not present, then genetic testing is appropriate. And we can have, there are two areas probably. So we have mutations in the receptor genes. So the receptors for GM-CSF are dysfunctional, or we have mutations in that affect the production of the surfactant, like surfactant protein deficiency B, C, in the lipid transportation, APCA3, etc. So there are specific genes that we can look for, but it should not be routinely in the first test to be done.
And in those patients where you suspect a genetic background, they also present at a much younger age, so also during childhood?
Yeah.
Okay.
Yeah, they do present, and yes, they can be in childhood, or on occasions they can present, teenage years or around their 18s, etc.
Okay, so but anybody who has this diagnosis and is younger than 30, you would suggest doing the genetics?
Yes, yeah, definitely,
okay.
yes, yeah.
Okay. And are there any risk factors for those patients that have been identified, like smoking or sort of a very hazardous environment in terms of pollution?
So there are definitely triggers, not causes for the disease, but inhalational exposures can be occupational exposures, and this is where we have secondary alveolar proteinosis due to occupational exposures to hard metals, etc. But also smoking has been identified as a trigger. How exactly it works, we don't know, but it is definitely a trigger. And one interesting observation is that in the past, when it comes, for example, to gender distribution, in the past, it was a lot more frequent in males compared to females. And this difference now has been minimized. And it is probably because of the changes in the smoking habit, could be one explanation.
Okay. A technical question. You mentioned that you could establish a certain level of anti-GM-CSF antibodies that would be associated either with the risk of developing disease, or maybe if they're not very high, then patients don't really carry a risk to develop. In our centers, it's always very difficult to compare the levels between different sort of labs because they have different setup, and the cutoff that we established here in Berlin might be completely different from the one in Paris or in Cambridge. So the reference that you refer to has been established in one center, or is this like a multi-center?
This has been
round
so.
robin?
This reference center is established in Cincinnati, which is considered as the international center for PAP, and these are the reference ranges that they use.
Okay, so
but I have to yes, no, please go ahead.
So that value measured in Cincinnati then is correlating with a certain level.
Mm-hmm. Yes,
okay.
Yeah.
Okay.
And of course, I have to say that not all laboratories provide the titers. They just give a positive or negative result, which again is not ideal.
Yeah, it's similar. It's a similar situation, I think, with other sort of anti-cytokine antibodies, where we also have to establish the functional relevance by doing the STAT assay, STAT1 for interferon gamma, or STAT5 in the case of GM-CSF. And I think in many cases, we still don't really know where the cutoff is. So we also, then we would stimulate with interferon gamma, and then we'd see, oh, nothing happens with 1 nanogram, and there's still nothing with 10 nanogram. But if it happens after 100 nanogram, is that still good enough for the body? We don't really know. So it's great when you have sort of the possibility to define the relevance just by measuring the cutoff, because the STAT assay is a bit more laborious, obviously, and you can't do it anytime. You cannot preserve the cells. You could do PBMCs, but then you don't have the serum, which you need to really show the functional relevance. So that's quite tricky.
And that's why it is very difficult to include it in really routine practice. But it can be helpful in specific changes. Yes.
Yeah. We have some questions in the tab and in the audience. One of them is about the reference centers. Is it easy to find when we have such a condition to be referred there?
I'm sorry, I didn't hear the question.
It's about the reference centers, because you said this is very important to be followed up in a reference center. Is it easy to find? How is it easy for a patient or a doctor?
So there are not. I don't think someone can access them. There is not a site or a PAP reference center to give this information. It is a word, of mouth more. But I think it is important to discuss at least with ILD expert centers, and then the physicians can be advised further.
Okay. And another question is about the kind of PIDs who are more susceptible to get that kind of evolution, I would say, to get an APAP. Can we flag some specific PID and then put any action to prevent this or anticipate it at least?
No, not to my knowledge. There isn't. I don't think there is a way we can predict that. We do not have anything available.
Yeah, and I think it's a different situation. For instance, in those anti-interferon gamma autoantibodies, we sometimes tend to identify them accidentally because they receive an interferon gamma test to check for tuberculosis, and we might have not known otherwise, and then we have the problem that we have to think about how to treat those patients. I think for anti-GM-CSF antibodies, there's no such sort of unwanted diagnostic test that could identify those patients. And coming from the other side, I think those patients that have been identified suffering from CNS infections, I think it's very, very rare that they do develop alveolar proteinosis. So it seems to be that either you get one side of the coin or the other one, but not both at the same time. It seems to be a very rare combination. And I think Maria also sort of mirrored or echoed that by her experience, that she had only 1 or 2 cases that went on to have serious infection.
Maybe if I may add, one might want to consider, in case of a PAP, an underlying genetic disease, which is a GATA2 deficiency, which you can look at the monocyte count on the hemogram as a differential. It can give you a hint. It's usually very low. And obviously look at the B cell count and K cell count, but it's not like super stringent as biomarkers, but it could help in particular because there is a risk of myelodysplasia and hemonc malignancy in this setting.
No, definitely it is important. And if we think that, I mean, autoimmune PAP is 90% of the cases, 4 or 5% is secondary PAP. So we're looking at a genetic background in only 5% of the patients. So yes, GATA2 is very rare, but we're looking at very rare cases. So it is important to look into that. That's a very good point.
And also, just adding on what you said, to screen for family members who might not yet be sick of all the phenotype, but then could be referred to a reference center and have the proper management.
Yeah.
Thank you very much. Maybe another question kind of linked to that. You mentioned that some of the patients might undergo a lung transplant. Obviously not all, but some. Would there be any risk of recurrence on the transplanted lungs?
Yes. There is a risk of recurrence in up to 20% of patients. But still, even if there is recurrence, because some transplant centers, I'm talking about the UK at least, can be reluctant to accept those patients because of the risk of recurrence. Especially, I'm talking about autoimmune PAP. The rest are a bit more challenging and require more thoughtful discussion. But even if it is that, then they should undergo transplantation, and if there is recurrence, they can be treated. It doesn't mean that the disease will behave the same the second time. They could be responsive to treatment.
And another question, maybe a bit naive, but is there any decision support tool for PAP that could be integrated into primary care or pulmonary practice to reduce diagnosis delay or variability?
I think in general, not in PAP and in general in interstitial lung diseases, which is my background, it is important to increase awareness. And we have been doing that in the UK with some webinars, talks, etc. I would not expect a general practitioner to diagnose PAP or even to suspect PAP, to be honest. But a patient, especially a young patient who has had symptoms for a year, should undergo an X-ray. That's very important. The X-ray will be abnormal, and then it will prompt further investigations and referral to respiratory team. But that's very important and can be missed. Then it is important, the secondary care before they reach an expert center to recognize PAP and not delay the diagnosis. And we're working a lot around that, at least in this country.
Very important. I think that we kind of reached the end of this hard talk, unless there is a last question or topic. No? So I want to thank both of you for discussing diagnosis of PAP, to Dr. Hanitsch for your question and perspectives, and to Dr. Kokosi for your very interesting talk. We got congratulations into the chat, and both for the interesting discussion, and also Nizar for introducing some more insights. We will now also share a short feedback form, which should pop up on your screen. It's very useful for us to show, to know your feedback and to hear your comments to continue to improve this concept. Thank you all of you for attending this new edition of IPOPI Hard Talks. In a few days, you will be able to watch it on the IPOPI YouTube channel. Don't hesitate to share it as much as you can. We have understood that we need to raise awareness about this condition, and many thanks once again to everyone who joined us from a different country from the world today. And a special thank you to our sponsor, Savara, for making this event possible. To our audience, stay tuned for the next edition of IPOPI Hard Talks. We look forward to welcoming you soon again, and thank you, and see you next time.
Bye-bye. Thank you.
Bye.
Bye-bye. Bye.